Raman. I hope I have correctly.
Perfectly.
Okay. She is the Deputy Dean and Senior Consultant Geriatrician, University of Malaya. She has many research interests, including frailty, sarcopenia, force, dementia, as well as aging in the child population. And she will be delivering the talk on building tomorrow's geriatric services, regional insights, and transformative strategies. Over to you, Professor Kamil Salman.
Thank you. A very good morning. And what a very cozy audience we have today. Thank you nonetheless to the organizers for the invitation. I'm very privileged to be here because I have been in Colombo for over 20 years. And so it's a very fine privilege to come back after 20 years talking about geriatrics. So in the 20 years, I've been serving in my University Malaya Medical Center as an academic researcher as well as a teacher at our medical school. And in that time, for 23 years since coming home from my training, we have set up our geriatric services from literally scratch. And it's a little, today we'll just give you a little insight as to our journey in setting it up in Malaysia and what the challenges are, and hopefully share with you some experiences that we can do maybe regionally as the global south in the body of research and data that we have collected over the years. So in building tomorrow's geriatric services, I think, Oh, it's on the laptop. Okay. So you may ask, why geriatrics? Now, for the very reason that the world population is aging, everyone over 60, by 2050 we will be 2.1 billion large in the country, in the world. And of course, 80% of that population is here in Asia, in ASEAN countries, in the Asia Pacific region. And therefore, we do need to actually build bigger and larger and anticipate the changes that we are going through right now. And furthermore, our health systems are very youth-centric, if you agree, and very, very much still quite reactive in terms of providing services. And when we talk about what we are experiencing in terms of global aging, we have found that lots of our older population are living longer. So that longevity is part of that triumph of modern society. However, what is the health span? What is the quality of life of years spent left as we advance in age? And that is a huge balance that we must all, as geriatricians, gerontologists, and medical physicians as a whole need to face. And in understanding and meeting the needs of older people, we must address the obvious thing that actually makes aging and aged care quite challenging across the world. Older people are multidimensional. There's not just one problem, it's not just one area or one organ. And they are also not just only multidimensional, they are also heterogeneous socioeconomically. And their needs, their priorities have evolved with our rapid urbanization. And somehow, and I can give a good example as my own country, political will is very important, and that governance to ensure that aging care, all the services for that aging population in meeting the needs of the global aging impact is so important in ensuring that our services stay alive and relevant. So let's talk about some realities that we have in our Asian region and beyond. And that is really that huge diversity, that multidimensionality of aging trajectories in our population. I think in Asia it's all going upwards, and the systems differ though. And as you see in Singapore, I think I always give it they're quite small, compact, one governance, one healthcare system, which is put to an ideal, but not quite realistic in applying in other countries which are bigger and less, more heterogeneous like our countries. So Singapore has a single agency with integrated care, the AIC, where they appoint one single agency to coordinate, deliver care, and ensure that the hospital service and the social services talk to each other and provide seamless care from hospital to home. and vice versa. So Japan also has a community integrated care. Now Malaysia, we are piloting these little health hubs in the community and creating these age-friendly ecosystems. But again, there are huge gaps, and it's usually mainly in the urban areas. So rural gaps still persist. So when we talk about gaps, concerns are that in all the countries where aging is occurring in a huge rapid rate, there's no national aging policies in quite a few countries, as you know. Geriatric training is limited. I came home about 24 years ago after training in the UK, and I was the first woman geriatrician, and there was only 4 of us. So, and having to set up that training and ensuring, that your colleagues are not sort of wondering, what are you? What is the geriatrician? What on earth do you do? Shall I call you for everyone over 65? So we needed to actually rebrand what we do, and of course, it was limited in the beginning, but there's other ways and some strategies which I'll tell you about how we can actually expand and ensure that surely, quietly, and more significantly, we can get geriatrics into every specialty of note. And let's not forget, digital innovations also help spread that word and should be integrated into mainstream elder care. So as I said, those systemic gaps are usually fragmented. But how do we fragment that hospital care towards primary care, social care, and get that ecosystem, seamless care going from fragmentation to integration? Of course, we need to acknowledge that lack of continuity across community, hospital, community, and home is still there, and therefore that seamless care, ensuring that we create that continuous flow of information, discharge, and having that sort of ecosystem of tertiary, secondary, primary, and community care talking to each other. So that integration is really key. And when we get from primary care to social care, those connections and communications need to occur. Often, what we find, these gaps occur because it's usually episodic when there's a need, very reactive versus proactive comprehensive care. So that's what we need to move towards, and I'm sure you all know this. And a lot of our hospitals are very age unfriendly, and that's needing to acknowledge. And the infrastructure is usually, especially old infrastructures like myself in Malaysia, Similar is the oldest first hospital that was formed in 1950s. So we have been building on top of it. So it's like, if you're elderly and you want to come to my hospital, it's like a whole maze. And therefore we do need to make it a little bit more. So all these gaps, systematic, poor integration, impact on our older person, of course, and their caregivers, and the community at large, and therefore we do need to make that available. And unfortunately, the access and the information, the awareness, the knowledge still is at a poor level when it comes to our older population, at least in my neck of the woods. So really, in every level that impact, whether it's social, economical, or environment, we do need to see, and that C strategy is what we do need to put in order to stabilize everything to do with aged care. And that's, of course, education and awareness, and all of us are here for that reason. And that healthcare provision and ensuring that whatever area of healthcare that you're at, you do need to sort of ensure that, we looked at the cardiology talks earlier, even in respiratory, in the diabetics, the care and management of the older patient is quite different. And therefore, acknowledging that and ensuring that that is not left behind is very important. Ensuring that the technology don't leave the aging population behind, and have the law and policies that actually integrate aged care into it is really quite key. And in Malaysia, where are we? We have already achieved nearly 15% of our population very soon, and we're an aging nation. We do have a national policy for older persons, and we're about to launch the next one. We have an action plan for our older person services, and we've got, most recently last year, a national dementia action plan. Only thing with these policies is, are we implementing them? Who is coordinating? Who is integrating? Who is actually regulating all that? So that's still an issue. And most recently, at least 6 of our cities have applied and are members of the WHO Age-Friendly City Initiatives. So putting aging at the heart of any community, any city, is actually one of the ways in which to try and get integrated understanding of what aging is about. You can't access healthcare if you don't have the transport. The outdoor spaces are not accessible, are not promoting social integration, empowerment, community participation. All that, taking care of the strategic moves towards healthy aging is so important. So we are trying to put that in our health white paper 2 years ago. Actually puts and pledges that most of our GDP goes to community care, because a lot of the care and strategic prevention and healthy aging needs to occur in the community, and that's where the money needs to go. So Malaysia's aging needs, I don't think very much different from Sri Lanka. We have a higher consumption of healthcare facilities with increasing age, but that need is actually divided into from the young, old, older, and oldest old, and definitely divided by the socioeconomic group below 40% income group. And therefore, a lot of our models of care actually need to find and implement and regulate and coordinate and integrate age-friendly solutions in meeting our needs. So just to give you an outline, as I think all of you already know, that when we want to do future-ready geriatric systems, we do need to think not just about that patient-centered care, but what are the relationships that bring that care together to communicate that care to the person and their caregivers. What is that continuity over the course of the lifespan? What is the multidisciplinary trans-sectoral teams that need to be able to communicate that age care? And of course, the technology that goes with it, but it's human-led. So what do we need to transform? Very briefly, it really is, the first strategy is workforce. And one of the things that we really needed to do, and as a young geriatrician coming home and really quite excited about starting geriatric services in Malaysia, we needed to get people to understand what we do. We needed to get therapists, allied health, all our partners, all our strategic partners like orthopedics, psychiatry, primary care, nutritionists, etc., public health, to be understanding of what it is. So we inserted ourselves. So geriatrics is a transversal competency, not a siloed specialty. So in our undergraduate curriculum, we insert ourselves in the orthopedics block, in the cardiology block, in the nutritional block, in the neurology block, so that every bit of aging is covered. Exhausting, but very necessary. And empowering a lot of our nurses, allied health professionals, lead to better models of care, because doctors, we can't do it alone. And aging is not about doctor-led. Transformative strategy 2, models of care. That innovation is very important, and ensuring that the needs of our really fragile, vulnerable, frail elderly managed at home with intermediate care units that's starting to expand. And of course, ensuring that every person that is involved in, from primary care to all levels of care, understand what a comprehensive geriatric assessment means, both in the acute and outpatients, understanding dementia, destigmatizing it, and creating community hubs for that, and integrating that preventive, rehabilitative, and palliative care in the community. And the third strategy we've mentioned earlier, policy and financing levers. That's so important. So embedding geriatrics, gerontology into our national health priority. Have more age-responsive health financing, incentivize, integrate, shared savings, etc., all our financial plans. All that is coming out, but there's no one coordinating body that we need to regulate and support long-term care. So these are some of the transformative levers for change. And I mentioned earlier that age-friendly ecosystem, which is why we're really subscribing to the age-friendly city. And I don't know whether it's Colombo part of the age-friendly city initiative. Well, it should, because it's really quite a nice, very compact city, and therefore, that urban planning is so important in trying to get planned services for aging population across the life trajectory is very important. For my part, really, the healthcare opportunities are what we've done as aging experts within Malaysia. That 4-step approach, we really need to future-proof our inpatient services. A lot of our older patients need to have actual bit more. That patient journey needed to be looked at. And step 2 was ambulatory and community care. We needed to actually get our stakeholders all aligned. Education and awareness, that is part and parcel of every strategy that we go through when we embark on aged care. And to ensure that every healthcare professional will have to learn to care for older people. So whether they're in public health, allied health, nursing, our undergraduate MBBS, biomedical science, or all that have some geriatrics or gerontology inserted within their curriculum. And that's policy. And of course, that for care interventions and training of older persons themselves. And therefore, what can we as specialists do now, and policymakers? That alignment of that health system is really important. I've mentioned the reasons why and how we have the strategies. And of course, developing age-friendly environments, developing long-term care systems, promoting healthy aging across the lifespan, and rebranding aging as a whole. And to be fair, that vision really is about ensuring that we age-attune our clinics, our elder competent hospitals. That's a way forward that we do need to sort of work on in Malaysia especially. Telemedicine has become a big part of our lives post-pandemic. Having concierge services, ensuring that older people are able to access and navigate our centres more efficiently. Any move forwards to try and get more stable services, age-friendly services has to be data-driven, AI-enabled, and of course culturally responsive, inclusive, equitable across our life force, our lifespan. In my hospital, my geriatric unit, we have now developed a virtual ward. We were the first to start in the pandemic time. So from telemedicine to outpatients, we've transferred either if they come into emergency, for example, and they really can't stay in hospital. They get more delirious, they're better off at home, and it's not too acute. We manage them, and then we give them an appointment where we do the walk around at home, provided that the caregiver is able to have an intelligent phone, do certain monitorings, etc. We ensure that a GP that is appointed to that neighborhood will be able to give the eyes and ears, take bloods, etc., and monitor. We reduce discharge rates, we reduce admission rates, and we reduce length of stay, and hopefully, in the long run, we're collecting the data, reduce mortality. So this virtual ward is first started in our geriatric unit at University Malaya Medical Centre, and is expanded to the other respiratory units, cardiology units, etc., over the next 5-year plan. And of course, regional collaboration, and is why I'm so excited and very honoured to have been invited to this very prestigious association gathering. And global South platforms are so important for us to actually bring together our training opportunities, research collaboration, and that policy exchange. And shared guidelines, of course, is very important. And I've been very honoured to be part of our frailty aging network, our sarcopenia, cachexia networks, all these related to aging. And of course, I've heard that our esteemed gentleman here is a member of our Malaysian Society for Geriatric Medicine, so thank you so much for that support. So that cross-border workforce development is also something that we aim to share. And of course, what I found in my 20 years of building our geriatric service and being part of that journey was to build people first, because if they don't understand the importance and are invested and become advocates of that geriatric service, then we will have lost from the beginning. So prioritize that integration and not just the expansion. We can build big, but we don't have the people. So we put people at the heart of it. And of course, move from these pilots that we've been doing to big platforms, virtual best, to actually try and get that bigger. And the future care of older adults really starts with the decisions that we make today. And really my closing message is we don't get a second chance at aging well. We have to do it now. So, but when we do get a first chance to build a system that makes it possible. So thank you very much, and I hope I didn't take too much time from yours, sir. Our Asia Pacific Geriatric Network is very excited to announce that we have a meeting on December 6th in Kathmandu in Nepal. So a lot of the regional geriatricians are coming together, so please come, and I will send the information to the society for your personal invitation. And Malaysia, in Kuala Lumpur, we'll be hosting the Asia Oceania International Association of Geriatrics and Gerontology. I know it's in 2028, but it's never too late to plan, and I hope to see you then. Thank you very much.
Thank you, Professor Kamarud Sarman. We will have a time for discussion at the end of all 3 presentations. For the next presentation,